Thank you, David, for inviting me, and I appreciate the opportunity to talk about this topic, which I have to say is not a topic I would normally have chosen myself to talk about, and is, I think the title speaks for itself. It's a tangled web of prognostic scoring systems in MF in which we need to sort of figure out what it means and how we're going to apply it in modern day practice. So I'm hoping to take you through this. It's a large slide set. I'm going to move through it rather quickly. I'm going to try to stress the points that I think are important to people in practice that are going to see patients with MF and try to risk stratify those patients. So this is my schema of evolution of prognostication in myelofibrosis. So the first scoring system that was widely available and used was the Lille score, created in Lille, France, and published in 1996. Then you had the discovery of the JAK2 V617F mutation, and then in subsequent years, the IPSS, the International Prognostic Scoring System, and then the dynamic IPSS, and the DIPSS Plus were created. We'll talk about those. RUX was finally approved in November of 2011, the only approved drug for myelofibrosis. And then last year, two new ones hit the stage, the MIPSS, I don't even know if you pronounce it MIPSS, I'm going to pronounce it MIPSS, MIPSS and GIPSS, GPSS, and we'll talk about what those two mean and whether they are relevant to you in clinical practice today and where we are today in 2015. So what are the First, I got to review. What are the primary causes of death in myelofibrosis? This comes from Dr. Cervantes' paper in which the IPSS was created. And here he shows that out of 1,000 patients that were followed in 7 large MPN centers, the largest, most common reason for early death or cause of death in MF is leukemic transformation. Now, this is not like de novo AML. It's worse prognosis, median survival somewhere between 3 and 5 months. And these patients don't really respond to induction chemotherapy the way de novo AML patients do. So this is really a bad outcome and remains a clinically unmet need in the treatment of MPN patients. But if you look at the rest of the patients, about 50% of patients died from direct complications of myelofibrosis, whether it's from bone marrow failure, thrombosis, cardiovascular events, infections, bleeding, or portal hypertension. So the Lille score was, I think, the first true attempt and widely used scoring system that was published in 1995, or was it 96, by Brigitte Brie, and basically took a very simple way of risk stratifying patients. You get their CBC. By multivariate analysis in about 195 patients with primary myelofibrosis, they determined that a white count less than 4 or greater than 30,000 is significant in influencing survival, and hemoglobin less than 10 is as well. Each was given a point, so you could have 3 risk groups. Low, 0 point, 1 intermediate, or 2 points gives you high risk, with median survivals that are shown here on this Kaplan-Meier curve of 8 years, 2 years, and 1 year. And the reason why I showed this, and it wasn't in the title of my presentation, is this makes the point that this is a heterogeneous disease, and not every 2 patients with myelofibrosis are going to walk the same path. So you can very early on see that with a simple CBC, you can communicate with anyone around the world. You can differentiate between patients that are going to do relatively well versus patients that are not going to do well at all based on hemoglobin and white blood cell count. And this may influence your treatment decisions early on in terms of transplantation or experimental therapy versus a watch and wait approach for low-risk patients. So that's CBC, that's the Lille score in 1996. Jump ahead to 2009, Paco Cervantes and his group on behalf of the IWG-MRT did a retrospective study of about 1,000 patients at a number of centers that treat PMF, and this was at time of diagnosis, did multivariate analysis, and came up with 5 clinical variables that are prognostic and influence survival, and that's age greater than 65, the presence of constitutional symptoms, a hemoglobin, again, less than 10, was seen in Lille score, high white count, again, which was seen in Lille score, greater than 25,000, and then at least 1% blasts circulating the peripheral blood. Each was assigned 1 point and provided 4 different risk categories as shown here with non-overlapping survivals. Okay? So this is probably a more comprehensive risk scoring system, taking 5 clinical variables and then segregates the patients into 4 risk groups with different median survivals. What was important about this study, it also showed 2 other things, I think, of note. One was that splenomegaly, or the extent of splenomegaly, didn't influence survival in analysis, and the presence of the JAK2 V617F mutation didn't significantly influence survival. So this is independent of those 2 features. When they went back and looked at the quality of this risk stratification compared to Lille, they proved that this had more prognostic power in determining outcome than the Lille score. So this became widely available and widely used, and particularly in the context of clinical trials. then it occurred, well, the IPSS was at time of diagnosis, that we needed a risk stratification tool that could be used in a dynamic fashion at any point after diagnosis as these risk variables are acquired. So Dr. Passamonte and colleagues, again on behalf of the IWG, went back and looked at over 500 patients and came up with a risk scoring system that used the same 5 clinical variables as the IPSS. So it's simple and it's the same variables, except here hemoglobin is weighted slightly more. You get 2 points because the hazard ratio was more significant in terms of its influence on outcome rather than 1 point in the IPSS. And this can be used at any point during the time when you see a patient. So you don't always have the counts and some of the other aspects of a patient when you see the patient 4 years later, if you weren't the first person to diagnose the patient. So this can be used when you see a patient real time to determine their risk score. And what they saw here was they had a low-risk population that had a median survival that was not yet reached at the time of analysis. Intermediate 1 group, which was 14 years, 4 years, and about a year and a half. So it really nicely pulls apart, probably better so than the IPSS, these different categories of patients that are going to do well or not well. And again, this is 0 points, 1 to 2 points, 3 to 4 points, or 5+ points in this scoring system. So here now we have the second reiteration, or the next step from the DIPSS, which is DIPSS+. So not to be outdone, there was a sense that we needed to better risk stratify and better tease out patients that are not going to do well, that may appear to do well in the DIPSS. And it was widely accepted that karyotype, as in many other malignancies, influences outcome. So there was a reanalysis and additional variables were included to risk stratify patients, including unfavorable karyotype, which is listed here. I won't go through it. You can read it. A platelet count less than 100,000, so thrombocytopenia was found to be a statistically significant risk factor for outcome, and the need for red blood cell transfusional support. So in this analysis, this was weighted a little bit differently. So it was the DIPSS+. So if you had high-risk intermediate 2 or intermediate 1 by the DIPSS, it was 3, 2, or 1 points. And then there were additional points added if you had unfavorable karyotype, a low platelet count, or if you had transfusion dependence. And what you get are, again, 4 non-overlapping survival curves called the DIPSS+ score. And this also perhaps is a more powerful prognostication tool than the DIPSS, as it incorporates other features like cytogenetics and the weight of cytogenetics in determining outcome. So that's the DIPSS+. Now, I think one of the reasons why this talk was invented was to get to the fact that now we've moved into a new era of mutational prognostication. So this is where I'm going to try to go through and make some sense. And this is where I think it actually gets maybe a little bit more interesting, perhaps a little bit more confusing. So many of you in the audience are probably aware of the fact that over a year ago, there was a mutation described in a gene called CALR that encodes for a protein called calreticulin. This is a multifunctional protein important for calcium homeostasis, protein folding and chaperoning. It's found within the endoplasmic reticulum, the cytosol, and expressed on the cell membrane. This is a gene that's mutated in exon 9 insertion-deletion mutations in approximately 25% of patients with ET, 25% of patients with primary myelofibrosis, and is mutually exclusive with JAK2 V617F and the MPL515LK mutation. It's not found in polycythemia vera. So if you have a PV patient, don't bother checking for CALR, particularly if they're JAK2 V617F positive. It won't be there. So this is an important mutation that's now part of our driver mutation set, which includes CALR, JAK2, and MPL. And then, as was alluded to earlier when David was talking, was triple negative. Triple negative means that you lack any one of these driver mutations. And what our Italian colleagues showed was that the presence of calreticulin mutation influenced outcome, was associated with patients that had more of an indolent form of primary myelofibrosis, less anemia, less need for transfusions, less risk of leukemic transformation, and better overall survival. Now, if you lacked CALR, your rate for leukemic transformation, this is triple negative, was the highest. So this gives you a sense that you can start to risk stratify just based on a single mutation or the presence of or absence of these driver mutations. So here we're looking at Kaplan-Meier curves of survival. This is stratified by their driver mutation status and then subdivided by their IPSS risk score. So this is low and intermediate 1 risk patients by IPSS and intermediate 2 and high risk patients. Probability of survival. What you see right away is that if you're triple negative, that really portends a worse prognosis. Even though you may fall, or your patient may fall, in the low or intermediate risk category, which should portend a relatively good prognosis, there will be a subset of patients that will likely do poorly, and identifying them by this triple negative status or genotype is one way of identifying them earlier, perhaps, and I stress perhaps because we don't know this, but it's not been shown prospectively, perhaps would even spur one to intervene earlier or consider transplant earlier in the course. So here's a Kaplan-Meier curve of the Italian group. This is probably the first, I think it's the first attempt of incorporating or integrating both clinical and molecular aspects of a disease, of myelofibrosis, in order to risk stratify patients. So this is an incorporation of IPSS and the driver mutation status. And here there are 5 categories with non-overlapping survivals that tease out a very low-risk patient population that are basically CALR positive and IPSS low risk, that do well, and then a very high-risk population that does very poorly with a very dismal prognosis that is usually triple negative in the high-risk category. So now we're combining molecular and clinical risk stratification. So you can already see things are getting more complicated, maybe more exciting, but definitely more complicated. Now, to take this one step further, Alessandro Vanucci, who was kind enough to provide me with some of these slides, looked at other mutations that are commonly seen in myeloid malignancies like ASXL1, EZH2, SRSF2, and created a mutationally high-risk profile versus a mutationally low-risk profile. So if you had any one of these mutations, EZH2, ASXL1, SRSF2, you were classified as mutationally high risk. If you lacked any of them, you were classified as low risk. And what he did was he stratified a number of patients by their IPSS score, and then subdivided them by their IPSS score, and then stratified them by their mutational genotype profile. So what you can see right away, which is interesting again, and this is the same concept, here you have in a low-risk population, you have a high-risk genotype that portends a worse prognosis. So again, this is teasing out patients that in a group of individuals would appear that they would do relatively well, that are probably going to do worse, and this may be another way of identifying those patients early on with genotype expression. So he then took it a step further and with multivariate analysis identified that the most prognostically significant mutation independently was ASXL1. So what he did here was he took 279 patients with PMF and then he sub-stratified them according to the ASXL1 expression or mutation status. And again, the point to be made here is that there's this group of patients who are ASXL1, that's a negative prognostic indicator, I've shown it to you now a number of times, that are going to do worse despite the fact that they may fall in an IPSS low-risk group. Again, prompting a physician to consider perhaps early therapy or transplant. Not to be outdone, Aiello Teferi then said, we'll take it one step further. We know calreticulin, I showed you, was a good prognostic indicator. We know ASXL1 is a negative. We will combine them, and this will be a new way of risk stratifying patients. So I apologize, the slide came out a little messy here, but you get the point. If you have CALR, which I said is a good prognostic marker, and you lack ASXL1, which is a negative prognostic marker, and you use these two markers, the presence or absence, to stratify patients, you get a group of patients that are CALR positive, ASXL negative, that have a median survival of 10.5 years. But if they are ASXL1 positive and CALR negative, the median survival is much worse, 2.5 years. Interestingly, if they're double positive or double negative, they fall somewhere in the middle. So here's another risk tool of risk stratifying using 2 molecular markers. Now this brings us to sort of the end, or the culmination of all of this. So these were 2 abstracts that were presented, one by Alessandro Vanucci, who was nice enough to give me his slide set. And this is the Mutation Enhanced International Prognostic Scoring System, MIPSS. It rolls off your tongue. So he took a cohort, a learning cohort of 585 patients with primary myelofibrosis. They had an overall survival of approximately 10 years. He then risk stratified them by IPSS. And then he did multivariable analysis and identified variables that come from the IPSS, that come from the DIPSS, that are related to driver mutation status, and then additional mutations that can influence survival, and were statistically significant in multivariable analysis, and then created a weight-based risk scoring system based on the degree of their hazard ratio, as shown here. And then, like all our risk scoring systems, you add them up, and you get, shockingly, 4 non-overlapping survival curves, okay, depending on how many points you get when you add these up. And again, the point is made, I think, rather nicely. Using this integrated system, you get a high-risk group that does very poorly, and then a low-risk group over here that does significantly better, and two in-between groups. They use a statistical method in which I've never heard of previously and had to read about. I don't even know if I can pronounce it correctly, but essentially it's a method in which statisticians use to compare the quality of two different risk stratification tools or methods, and using this accepted method of comparison, this MIPSS score was found to be more prognostically powerful in predicting survival than the IPSS. And when you look at whether there was concordance between the MIPSS and the IPSS, you see that at least in the low risk group, there was 77% concordance if you were risk stratified by IPSS versus MIPSS. But I think the important part here is that you get this little sliver, 6%. And again, you see the same theme coming up again, identifying a subgroup within the population that should do well, or relatively well, that are predicted to fall perhaps in the MIPSS in a worse prognostic group that may not do as well. Again, prompting one to consider earlier intervention or perhaps transplant, which is really why we use risk stratification to begin with, because our therapies are really risk-adapted therapies in myelofibrosis. Now, lastly, the GIPSS, GPSS. So this is an integration of mutation and karyotype. So this is just using karyotype, which in many malignancies or hematologic malignancies has influence on survival, and genotype, which we just showed, is important. So this is Teferi's latest abstract. To understand this, you have to go back and understand that he also revisited risk stratification by cytogenetics. So he previously, you either unfavorable or favorable when you risk stratify patients by IWG criteria by cytogenetics. He went back and looked at a tremendous number of patients, 903, and redid analysis of cytogenetic influence on outcome and survival, and came up with 4 different risk groups based on cytogenetics alone, okay? A low to very high group, and shown here, monosomal karyotype, inversion 3, isochromosome 17q, -7, 11q, and 12p, fall in this very high group, okay, with a pretty bad survival, less than a year. Then he took this, and he said, okay, well, these are the sorry, whoops. You know, these are the poor prognostic groups here, this high and very high. We know the triple negative is bad, and he plugged in a number of other different variables that have been shown in various other risk stratification systems, all of which I've already talked about, and found that these were statistically significant in terms of their hazard ratio in predicting outcome in an independent fashion, assigned points based on that hazard ratio, and again, the same concept, added the points up and created survival curves that are non-overlapping, that tease out a low-risk patient population where the survival had not been reached, and a high-risk patient population in which it was about 2 years. So this is based solely on integration of just karyotype and mutation. There's no age, there's no blast count, there's nothing else that we've used previously in the IPSS and DIPSS era. So this was validated in a cohort of 183 patients in Alessandro Vanucchi's database. And what he did was he collated, so he grouped together the low and intermediate 1 patients and the intermediate 2 and high patients, and showed by applying this GPSS prognostic scoring system, you have a clear difference in outcomes in these 2 patient populations in this independent validated cohort. So I apologize if this was quite a talk. I think it was quite a talk, but this is my summary slide, and we'll go through it point by point. So risk stratification in MF has become increasingly refined and confusing in 2015. I think that's a true statement. I don't think anyone would disagree. Driver mutation status appears to strongly influence survival. That is also true. So CALR mutation, good prognostic marker for patients with myelofibrosis when compared to their JAK2 V617F or MPL colleagues, and the absence, perhaps, the triple negativity really predicts for a poor outcome, which is independent of the modern IPSS or DIPSS risk scoring systems. IPSS, DIPSS, MIPSS, GIPSS accurately predict outcome for your patient in the office. For your individual patient, you must be using these risk stratifications so you can clearly tell them how long they will live. That is absolutely false. You can never tell an individual MF patient, and sadly, I meet patients where they were told they have exactly 2.2 years to live based on their risk stratification. That doesn't work that way. These tools remain best utilized in the setting of clinical trial and consideration for hematopoietic stem cell transplantation. I think that's a true statement. That's really where these are best used. They're also, best used to get publications on your CV, but for the clinician in the community, this is probably not going to be all that helpful, although I think understanding certain pearls from it are important. For example, the influence of CALR or triple negativity, for example. Sorry, I jumped ahead, I got excited. It is important that the clinician in the community establish the MIPSS and GIPSS, and then presently, the newer cytogenomic scoring systems do not influence ruxolitinib treatment decision-making. I think in the community where you're using ruxolitinib, the only FDA approved for most physicians in the community with their treating their MF patients, this is really what you're interested in. Does any of this really matter to you or matter to the patient when you're making a decision about ruxolitinib? And the answer is yes, it doesn't. I worded that weird, but yes, the answer is yes, it doesn't matter to you, meaning that it doesn't influence your decision-making when you're treating someone with ruxolitinib or considering treating someone with ruxolitinib based on their mutational status. Although I would highly urge physicians in the community that are treating patients with myelofibrosis to refer those patients so that we can validate these scoring systems prospectively and better identify how to treat patients that might tease out of their respective scoring systems by IPSS and DIPSS and hopefully improve their outcomes. So I always like to meet any MF patients. I don't discriminate based on their risk score, and that's my contact information. I really appreciate your time and attention to this talk, so thank you.